Welcome everyone to day 4 of Mercy Care's Connections Conference. So at this time, I'm going to turn it over to Matt Joya, and he is going to introduce our presenter.
Thank you, Laura. Really appreciate it. Thanks everybody for joining. As Laura shared, my name is Matt Joy. I'm a grants administrator for Mercy Care. Tina is, I'm going to do a little ad hoc here. She's a licensed social worker and director of special programs and initiatives for community medical services, and has over 15 years experience working with nonprofit organizations, women-centered services, domestic violence groups, SMI populations, general behavioral health. It looks like she's even had some work with the Peace Corps and substance abuse and recovery services. A lot of the work that she does is primarily focused on opioid use disorder and medication-assisted treatment for the last 6 years. I know that they've been a great partner with us and have been running one of our 24/7 access points for medication-assisted treatment. Without further ado and stealing any further of her thunder, I'm going to go ahead and pass it off to Tina and enjoy the presentation. On to you, Tina.
Awesome. Thank you, Matt and Laura, for the introductions, and thanks for allowing me to present today and spending your time with me. So I'm going to go ahead and get started. I typically, disclosure, talk really fast, so I make a concerted effort to slow down, but just, I don't know, jump out anybody if I'm talking too quickly throughout the presentation. So I will get started. Today I'm going to be talking about medication-assisted treatment. We'll use the term MAT for medication-assisted treatment. And as mentioned, my name is Tina. I work with Community Medical Services, and it's an opioid treatment program. We are primarily located in Arizona, but we have clinics throughout the country. And our main goal is working with individuals with opioid use disorder and just helping people heal and reach the point in their life that they want to be. So our vision is just leading the change to eliminate the consequences associated with substance use disorder in our communities. So our primary goal in the recovery process isn't just to stop the drug use, it's really to focus on all the different consequences related to drug use. And so we'll focus on that some in the presentation. And then our values, listening to and honor the reality of those who we serve. That's for our members, our staff, our community members, our funders, everybody, and just really working together and respecting where everyone's coming from, even if it's not always the same viewpoint or stance that we are. And then evangelize for practices grounded in science and evidence. That's really focusing on evidence-based practices and evidence-based outcomes. So really focusing on that rather than I feel this is the best thing, but what does science and research show is most effective. I value people who are passionate about making an impact. That goes to, again, our clients, our staff, just really focusing on that. And then seeing challenges as opportunities to demonstrate initiative. And I love that this is a value for our company, but I think it's important for all of us, is that right now, I think in communities, we're encountering a lot of challenges and barriers. And how can we take those, what may seem like inopportune times, to make a change and use it as a pivot point to try something different. So just like this conference and how we're all here virtually, there was a barrier, COVID, that presented that we couldn't all be together and we couldn't go to conferences. So being able to demonstrate initiative, show and try new things, and the end result is that we're all able to be together in a virtual platform, and has opened up a lot of doors in other areas as well. So always like to talk about these just because I think as an agency, this is where I come from. I'm proud of where I work and I love it, but I also think it's important for all of us to try and find something that we love, and it's, we spend a lot of time doing it, and so focusing on that. All right, so today in general, I'm talking about just in general medication-assisted treatment, opioid use, kind of different resources. So it won't be agency specific necessarily, though at the end I'll be talking, as Matt had mentioned, about the different 24/7 access points for members throughout the community. So the opioid epidemic in general, drug overdose is a leading cause of accidental death in the US. It's higher than accidents, it's higher than any other accidental death. And I think that's important. That's definitely been a pivot over the years. In the course of our conversation today, an estimated 6 to 8 people will have died from an overdose related to opioids. And so just letting that sink in as far as something that can be preventable with naloxone and other overdose reversals, and yet still people are dying every single day, every single hour, every minute. And what can we do as a community and as human beings to be able to stop that and prevent it as much as we can? So an estimated 2 to 6 million people fit the use for opioid, or for the definition for opioid use disorder, yet only about 20% of individuals, so approximately 2 million, are seeking treatment for opioid use disorder. There's a study going on right now, or research with every different opioid treatment program in the country, to see what the actual numbers are for individuals in opioid treatment programs. The other piece of that is people can be in treatment that is not medication-assisted treatment related, or they can be in other forms of treatment. And a lot of times it's confidential, so it's hard to really get what those numbers are. But it's estimated that around only 20% of individuals will seek treatment. Talking more about the overdose, I think it's important that there's just a lot of statistics out there that are really scary and just things we should really always pay attention to. 91% of individuals who will overdose will receive the same prescription for the same medication on which they overdose. And so let's say I'm prescribed oxycodone and I overdose, 91% of individuals like myself will receive the same prescription. And so looking as far as society and prescribers, how can we change some of those different things or keep people informed and safe in whatever medication they're receiving or whatever illicit substance they might be using. I have the box of me talking where I see people and it's covering some of my screen. Right. Okay, it's minimized. So there's the epidemic. So prescription overdose is mentioned, leading cause of accidental death. This goes into a lot of the same statistics, talks about the number of individuals who might be affected. So looking at children affected, it's projected to increase up to 4.3 million. And then we talk about how many people are dying. Those are typically adults or young adults. And so children growing up in those same environments, possibly without their primary parent or caregiver, a huge cost to hospitals, to society as a whole, and we're losing a huge part of our population. 2% of individuals with opioid use disorder die every single year. So 2% of people with this disease die, and that's a huge number. That is just, it's heartbreaking and it's staggering, and that's why we like to talk through it and educate as much as we can. There's prevention, different aspects that we can do. There's also the engagement piece and then the treatment. And so that's what I'm going to focus on today. If you look right here, the 11 to 26 of people with opioid use disorder receive treatment. And among those, 34% of those individuals receive medication-assisted treatment. And so medication-assisted treatment, what is it? So it's primarily used for treating opioid use disorder, and it involves the use of medications in combination with the counseling and behavioral therapies. So I think that's a really important distinction that today we'll focus on medications because that can be a little bit more confusing. And people have less knowledge generally about the medication, but it's not just the medication, because if it's just medication, a lot of people can go to their PCP, their primary care provider, if they have pain and they get a prescription for methadone, for example. However, when it's with opioid use disorder, it's the marriage between the two. So you're treating with the medication component as well as the counseling and the clinical pieces of it. And the counseling can be counseling, it can be case management, it can be peer support. It's all those other pieces in conjunction with the medication. So it's not just the counseling, it's not just the medication, but medication-assisted treatment is treatment of all those different aspects and incorporating those different pieces. And so the different medications utilized, they work to normalize and reestablish the brain chemistry and block, sorry, typo, there's actually a couple typos in this one, block the euphoric effects of the opioids, help to relieve the cravings, normalize body functions, and help with the withdrawal. So withdrawal is also a typo, withdrawal symptoms that can be debilitating. So medication-assisted treatment, just like all different aspects of treatment, it's a tool, and it can be used in conjunction with other tools. So people can be on MAT and be in a residential program. They can be following a faith-based program or 12-step while on MAT. There's a lot of different ways it can work in conjunction, but this is the general cornerstone of medication-assisted treatment. In general, there are 3 primary medications that are prescribed, are FDA approved for medication-assisted treatment. The most common is methadone, and then there's also buprenorphine. So buprenorphine is known, can be in the form of common brand names, Suboxone or Subutex. There's Naltrexone, more commonly known as, or injectable naltrexone, more commonly known as Vivitrol. So typically here might be here methadone, Vivitrol, Suboxone, and in general, those are the 3 distinctions. These different medications all affect the brain differently and work differently. So methadone specifically is a full agonist. So it generates an effect and covers and generates the whole opioid receptor. So all of these affect the opioid receptors differently. So methadone is a full agonist, completely fills the opioid receptor, which can help with withdrawal symptoms, with cravings. Buprenorphine is a partial agonist, so it has a more limited effect. It has a ceiling effect, which means that if people, for example, on the max dose that's allowed to be prescribed are still experiencing withdrawal symptoms or cravings, you can't just increase the dose amount because it has a ceiling effect, which means if they take more of it, it's going to have the same effect. So sometimes that might be one of the barriers for individuals on buprenorphine, is that they're still experiencing withdrawal symptoms or cravings, and they might not be able to increase the dose. Versus methadone, you can be on, 1 milligram up to whatever, and it's individualized on that. And then naltrexone, it's an antagonist, completely blocks the effects. So blocks the effects completely. Any opioid trying to come in is going to bounce off. It's not going to be able to come, and so people aren't going to experience any of the different effects of the medications on that aspect, or the opioids that people might be taking. On a therapeutic dose of both methadone and buprenorphine, it shouldn't cause any of the euphoria that contributes to the typically characterized uncontrollable drug-seeking behavior with opioids. They're both long-acting opioids, so that's different. So you typically would take, your prescription, your medication once a day. So for methadone, has a long-lasting half-life, so 24 to 36 hours. Buprenorphine has a long-acting half-life as well. So what that means is that with short-acting opioids, for example, heroin, people use it pretty frequently, and when you stop using it, you can experience withdrawal symptoms, and you start to feel really sick, and that can happen after a couple of hours, depending on your body. So with long-acting opioids, they're more defined by that you can take them less frequently. You can take them once a day, and it has the same therapeutic effect because it's circulating throughout your body for the whole 24 hours versus just every couple hours weaning off, or going away, or waning off, I should say. And then also with the tolerance, you can get on a stable dose and be on that same therapeutic dose for years if necessary, versus other opioids. Typically they're characterized by a dependence to it, and then a tolerance, which means you can't use the same amount to get the same effect. So you might start off using twice a day, or using, let's say, 1/4 gram, and then you start using that same amount and you don't feel any of the same effects. So then you increase it to, let's say, 1/2 gram and then 1 gram, because you're developing a tolerance. So you need to use more of the same thing to get the same initial effect. All right, just another way to look at these different medications. This will talk about the route of administration. So methadone typically is used in liquid forms in opioid treatment programs. Pill or wafer forms are also available. Buprenorphine, depending, there's generic forms of it, and it can be a film or a pill. And then there's also implants. And then naltrexone can be an oral formulation or the injected extended release injectable, and that's the bottom one is what's commonly known as Vivitrol. In general, methadone for opioid use disorder can only be prescribed in an opioid treatment program. Buprenorphine can be prescribed in an opioid treatment program as well as by a prescriber with the right credentialing and waivers. And so a lot of prescribers, there's been a lot of initiatives throughout the state and country to get more prescribers, more doctors or PAs or nurse practitioners with the availability to be able to prescribe that medication. And then naltrexone the same, any healthcare provider with prescribing authority. So anyone who can prescribe can provide naltrexone.
Tina, we had a question on that for naltrexone. Does that curb the cravings?
So there's not tons of research. It's a newer medication. That's a great question. There's not a lot of research. Some people say yes, some people say no, but I think across the board, all three of these medications can help with the craving portion of it. It completely blocks it. So one of the challenges that people have experienced with naltrexone is that in order to get on naltrexone, let me go back to this slide, it completely blocks the opioid receptors. So in order to get onto it, you need to be off all types of opioids it's different to every body, but between 7 to 14 days. And so otherwise you'll go in extreme precipitated withdrawal, which sometimes requires hospitalization, not fun at all. And so in order to get on naltrexone or injectable, let's say Vivitrol, you have to be off all opioids. That in of itself can be a big barrier. So you have to get to that point, but once on it, people have expressed that it does reduce the cravings once you're on it. Thanks for that question.
Thank you.
Mm-hmm. Absolutely. So the withdrawals versus the cravings, I think a kind of way to look at it in our minds is that withdrawals can include cravings, but withdrawals is typically seen as more of the physical portions of it. The cravings are more the psychological aspects of it. So individuals, they might take their first dose of medication or take their first, this is before getting treatment or before the long acting. But at 72 hours, physical symptoms typically peak. And so when people talk about withdrawal symptoms, chills, fever, body aches, diarrhea, insomnia, muscle pain, nausea, dilated pupils, not a fun process at all. Now, around 1 week, the physical symptoms start to lessen. So still some fatigue, sweating, body aches, anxiety, irritability, nausea, but they're starting to lessen. Now, between here and here, these 1 to 2 weeks is typically when people would get the injectable naltrexone. And sometimes these withdrawal symptoms right here are so debilitating, that's what causes people to continue to use, or can cause people to continue to use. So that's one of the barriers sometimes, is that it's hard to get to this point sometimes for people to be on or to get on the injectable naltrexone. And then after about a month, there's cravings and depression, which are more those other pieces. So those symptoms can linger for weeks, months. You can see it for more extended periods of time. And those are more the psychological urges that people experience. And so again, the withdrawals can typically last maybe a few weeks, but then the cravings can last more significant amount of time. And that's why when we focus on, in the recovery settings, relapse prevention, it's knowing what are triggers, when we start to experience cravings, have drug dreams, any of those things, how can we address it? And that's really where the therapeutic piece comes in, because the medication point can help with this and stabilizing and helping with the withdrawal symptoms. It's really the cravings that we want to focus on in the therapeutic setting as well. So always a lot of questions as far as which medication is best. And the answer is none. The best medication is what works best for you. And so, people respond really well to Vivitrol. They might respond really well to buprenorphine. They might respond really well to methadone. A lot of times it can be pretty polarizing. People might have said, oh, I tried that and I hated it. I'd never go back. But as mentioned, every body is different, just like every disease affects the body differently, and recovery looks different for everybody. So there's no specific medication amongst the three. There is more research. Methadone has been around the longest, so there naturally has the most research around it. Suboxone and buprenorphine have a lot of research as well. Injectable naltrexone has less research just because it's newer in treating opioid use disorder. So less research, but again, doesn't mean anything. One is better. Again, whatever works for the person is what's going to be the best for everybody. In general, what the research has shown is people respond better to methadone than buprenorphine, and more people respond better to buprenorphine than to naltrexone. Again, research is out, and it's newer and newer research. Newer medications. So with more research, different things might come up. But just knowing that all three of these medications together have saved thousands and thousands and thousands of lives. So medication-assisted treatment, like how effective is it? What are the benefits of it? So it helps with, as mentioned, the withdrawal symptoms, can help reduce cravings and or block the effects of opioids. So I think that's a huge piece of it. And what evidence has shown is the MAT, so medication-assisted treatments, more effective in treating opioid use disorder than any other treatment. And again, it's not minimizing the benefits of other forms of treatment. If people go into detox, if people go into residential, and that saves their lives, that's what we want. Anything to help the individual, but just research showing for specifically opioid use disorder, MAT has the most research showing that it's the most effective. But again, there's success with every form of treatment out there. Some of the benefits of medication-assisted treatment, it's individualized. So all the programs, as mentioned, medication-assisted treatment, it's the treatment aspect of it. They're clinically based. They focus on the unique needs of the individuals. So every person would have to have a treatment plan that's unique to the individual and whatever their specific goals are. There's definitely, you see a reduction in drug-related deaths, 8 to 10-fold decrease in drug-related deaths for individuals on medication-assisted treatment. See reduction of IV drug use, HIV, AIDS, Hep C, reduction in drug-related crimes, improved family stability, improved pregnancy outcomes. And so, when talking about ongoing use, 5 to 20% rate of continued opioid use for individuals on medication-assisted treatment, which might seem really high from one perspective, but when you compare it to some of the abstinence-based programs, what research shows is those hover around 60 to 90% continued use with abstinence-based programs. And again, this isn't a plug for one or the other. It's just saying that all forms of recovery and all forms of treatment really work for individuals. It's really about the treatment matching and finding individuals that respond better to one versus the other. And same with the medications prescribed. Some people, as mentioned, respond really well to methadone. Others, it's pretty polarizing. They hate it, and they respond really well to buprenorphine. So just finding what works best, and it might be faith-based or it might be MAT. But again, what research has shown is that MAT has the best results in general in dealing and addressing opioid use disorder. Healthcare savings. So for every $1 invested in addiction treatment yields $12 savings in overall societal costs in employment, in hospitalizations, in jail, in crime, all these other aspects. What you can see is individuals involved in MAT, they're associated with a 17% decline in expected emergency department use. And then this one is a huge one, 50% reduction in healthcare costs for those utilizing MAT services. When you're in MAT services, you're typically focusing on the other aspects of your life as well. So it's not just that you're coming into treatment and all of a sudden it's just focused on your drug use, it's focused on all the other aspects of your life. So individuals who use drugs also might have other things going on, and drug use might be one issue that they're dealing with, but what else does it come down to? And I think the treatment setting, that's what we always want to try and focus on, is that people shouldn't be defined by their drug use or their abstinence. They should be defined by who they are. And so in the treatment setting, we really try and focus on all those other aspects of their life. That drug use is one piece of it, and that's typically the presenting problem, why they come into treatment, but it's not the defining characteristic of who they are. So how can we work with individuals and how can we individualize their treatment to help them focus on their specific goals? And then you see that in healthcare, or as the earlier slide showed, that improved pregnancy outcomes. So if individuals are pregnant, helping them with OBGYN, all those, finding OBGYN or prenatal care, all those different pieces. But when they're involved, you can see the reduction in healthcare costs overall. Medication-assisted treatment has a lot of different myths and misconceptions, and so I like to spend some time on these ones. And there's usually a lot of questions around this, so we can talk through some of these. But with medication-assisted treatment, because it does involve the use of a medication, a lot of people ask and have questions as far as, it's just trading one addiction for another. And addiction, by definition, it's a chronic relapsing disease characterized by the compulsive drug seeking you use despite harmful consequences. So, it might be that you're involved with DCS and your kids might be taken away or your parental rights might be severed if you continue to use, and you continue to use despite the negative consequences. There's long-lasting changes in the brain. So that's the definition. When you're in treatment, as mentioned, the medications prescribed, you don't build a tolerance. So you can be on a therapeutic dose for 1 to 20 years, or however long it is. And we'll get to that point in a minute as well. But that you're not involved in the dangerous activities at times. So when someone can't stop taking a drug, or they have to continue to take a medication or a drug because of the debilitating withdrawal symptoms, when you can affect that and change that, then it can really help focus and just normalize the brain so you can focus on the other aspects related or going on in their life. So again, it's not just one addiction for another. You're taking a medication as prescribed. So I always like to say that. It's not like you're just getting some pill on the street. It's actually prescribed by a medical provider. It's in a treatment setting. People typically have to take their medication for methadone specifically and for buprenorphine. You take it on a daily basis. The injectable naltrexone is typically an injection once a month, but all of them require time commitment on behalf of the individual. And it's not just that they're coming in there and getting high or anything else like that. It's really focusing on the therapeutic setting and the therapeutic pieces of it. And it really helps individuals disengage from those drug-seeking behaviors that are causing them to maybe be involved in crime, and focuses on just getting their life back to where they want to be or back to where it was before the start of drug use. Another myth is that it's not true recovery. And so, I think if we're having this conversation 10 years ago, it'd be a very different conversation. I think MAT and the 12-step community and abstinence-based community have come a long way together. There's still definitely stigma out there regarding drug use and medication-assisted treatment. But I think it's really important to focus on, people on an MAT, it is a form of recovery, absolutely. And again, recovery is individualized, and it's not us to judge what recovery looks like for you or for this person. It's your self-reflection and how you perceive your recovery. But it's defined by recovery, defined by the ability to perform the basic functions, fulfill your responsibilities without the use of a drug or another substance when you're using that. And so it's definitely achievable with medication-assisted treatment. You're able to perform your normal functioning, all those different aspects, and fulfill your life. We talked about the risk of overdose. It doesn't increase the risk of overdose by any means. It reduces it for people on medication-assisted treatment. Methadone in particular it has to be prescribed. It can, and providers need to know how to prescribe it and how to, it's a controlled substance for a reason. And so that's an important piece just because it does have a high risk. It could, just like any opioid could. So it's carefully monitored, but it does not in and of itself increase the risk of overdose. In fact, when people are on it, it reduces the risk of overdose. MAT, another myth, is that it should only be used in the short term. And that will give you a really harmful misconception just because it's not. I mean, what research shows is that people respond best when they're on MAT at least for a year. But again, it's really individualized. Some people might have been in and out of treatment for the last 20 years of their life and get on MAT and it works and helps them lead the life that they want to lead. And so they might say, I'm going to be on this forever. It's really individual based. And I think that's important for us to know that it's individualized. It's not just me saying, hey, I think it's time for you to get off. You look like things are going great in your life, or hey, you're really struggling. You should be on forever. It's really working with individuals on what works best for them and how long they want to be in it or on it. People are the narrators of their lives and they have the control over that and helping them lead the life that they want to lead. And if that's with or without MAT, that's up to them. And again, it shouldn't only be used in the short term. I'm not saying 100% time. It should be used long term or forever. By any means, it's individualized. Okay. All right, next one. MAT programs attract crime and attract individuals who use drugs into the neighborhood. So there's a lot of, not in my backyard, or people, I don't want a program in my neighborhood. And the reality is that opioid use disorder, affects so many people. In general, substance use right now, it'd be hard to find, imagine anyone on this call who hasn't in some way been, in some capacity, been affected by drug use. And so to say that, we don't want people coming into our neighborhoods or anything like that, we're not talking about, quote unquote, those people. We're talking about you, me, our brothers, our sisters, our colleagues. It affects everybody. And so it really is our community. It's our neighborhood that we're trying to address and work with. And, if I want to say, let's try and get you into treatment, you have to go to California, you have to drive an hour. The reality is that's a huge barrier. So you want to try and get treatment and remove as many barriers as you can and get treatment as close to individuals as possible or as convenient as possible. As far as attracting crime, there's not research showing increase related to crime regarding opioid treatment programs. As far as like looking at rates of convenience stores when they go into neighborhoods, typically have higher rates of crime. And then when it says, I think the misconception, attracting individuals who use drugs into the neighborhoods, it's not attracting individuals, it's providing the treatment for those individuals who are actively using drugs. And so again, when we talked about the benefits of medication-assisted treatment and just treatment in general, it's that you see a decrease in all those crime-seeking behavior, or all those possible criminal behaviors. And so there's that benefit as well. The prescribed medications cause impairments, so individuals can't drive, effectively parent, work, etc. Huge misconception, because when people are on a therapeutic dose, what it should feel like is nothing. It should feel like a normalization of the brain. You shouldn't be experiencing withdrawal symptoms. You should not be experiencing cravings. You shouldn't be overly sedated. It should just be stabilizing the brain and the opioid receptors. And so people 100% can parent, they can work, they can drive. Again, on a therapeutic dose, people can do any of those different activities. And working in an opioid treatment program and working with, I'd say, like thousands of individuals throughout the years, I see all these different things. I see people come into treatment when they're pregnant, let's say, become amazing mothers and or future fathers as well, and definitely be able to parent effectively, work, hold down jobs, finish school, all these different aspects. And so, again, there's a lot of stereotypes as far as what is methadone or what is Suboxone, or people on it are just getting high, and the reality is that's not the reality. And that ties into the next one. And then as far as too expensive, typically people are using have substantial habits when they're coming into treatment. And so in general, studies across the country It's typically lower in Arizona, but it can be like averaging about $120 a week. Some are down to like $50 a week, depending on the state. But in Arizona, I'd say it's between $50 to $80 a week for methadone. Buprenorphine can be a little bit more. Naltrexone can be a little bit more as well. And so with that, there's a lot of different insurances now. I apologize, dogs barking, but there's a lot of different insurance, commercial insurance, as well as Medicare can cover the cost of treatment as well now. So that's one of the different aspects. That started in about 2020, so that's something newer. And that's a huge piece of it, just because insurance has been a barrier. I apologize. It's been a barrier in the past, and there's a lot of different opportunities, as well as in Maricopa County, we'll talk on it. There's SABG block grant funding, so Mercy Care works with different providers. So there are different funds to be able to provide treatment for individuals when there are barriers or financial barriers for them getting into treatment. And the goal of us in our communities is just to do everything that we can to remove as many barriers for people wanting to seek treatment or seeking treatment. Okay, so stigma reduction. I think that's a huge piece because there's tons of stigma associated with medication-assisted treatment, with recovery, with drug use, all these different aspects. And so for stigma reduction, I focused on 5, but there's hundreds of talking points that we can focus on. So it's definitely not characterized or individualized to just these 5. Like I said, stigma reduction can focus on anything, but some of the main ones are when you focus on no more labels. So in the past, I think it was pretty common to hear people like, oh, they're an addict, they're a junkie, and just not defining people and labeling them in those different things, or even the words, like, well, are you clean? Are you dirty? I've been clean for 3 days now. Okay, but that implies when you're using, you're dirty, and there's negative connotation with that. And so I think using language is really important. Like for us with drug screens, instead of saying like clean or dirty, just normal. Do you have a normal drug screen? Presence of things that are prescribed and the absence of anything illicit or not prescribed, or an abnormal drug screen. Okay, and that's the same as if you get your blood drawn for any other type of medication that, not medication. If you get your blood drawn for anything else, then, if it's abnormal, there might be something else detected in your blood. And so those are normal terms to use with it, and it's not labeling. Using the person first language, I think that's really important. You wouldn't just be like an addict or drug user. It's just a person who does some type of behavior. A person who uses drugs, a person who injects drugs, a person who is experiencing homelessness. You remove the stigma associated with those language and use the person first language rather than a homeless person or someone characterized by their disease, a schizophrenic. You would never talk like that, or we never should. We should say a person experiencing homelessness, a person diagnosed with schizophrenia, a person who uses drugs, a person in long-term recovery. And so I think language makes huge difference, and how can we all work together to focus on the different pieces of reducing the stigma associated with, again, drug use in general, or opioid use in this aspect. Addiction as a disease, not a moral failure. And so there's been a lot of research, and there's countless research out there as far as addiction as a disease. And so I won't go too much into that. But I think the old thing, the old kind of approach to addiction recovery was like, just stop using. It's a moral failure. It's just stop if you wanted to, and or just stop on your own. And that's not the reality. And so addiction is a disease. It's characterized, and the definition is a chronic relapsing disease. And so it follows the same disease trajectory as other chronic relapsing diseases like asthma, like diabetes. When we talk about, someone who might have diabetes, and they eat a donut, you're not gonna say, well, then you shouldn't get your insulin or anything else like that. You still work with the individual with the medication. But also if someone let's say has diabetes and is eating donuts for breakfast every day, you wouldn't just say, okay, here's insulin. You talk about the lifestyle changes that need to accompany the medication. If someone has asthma, it might be the same thing. So again, there's the lifestyle components of it, the behavioral components of it, as well as the medication. So it's not just you have this medication or you have this medication, it's the medication and the lifestyle changes and behavioral changes that go with it. And then focusing on any positive change. Oh, I skipped the drug use falls along the continuum. A lot of times we think of things in such dichotomy, like black or white, that you're using or not, you're in recovery or you're not. And the reality is there's a whole continuum. People might be in recovery their whole lives and from time to time use. There's a lot of different aspects. And again, because recovery is so individualized, it shouldn't be us to say, okay, where do you fall within that? It can be complete abstinence to chronic dependence and everything in between. And focusing and realizing that you know, full 100% abstinence is not the goal of everybody. And so there's not just one right way or wrong way to address recovery. It's different for everybody, and focusing on those aspects. And then focusing on any positive change. And I think this in the treatment setting sometimes can be really hard to focus on, just because people, you know, oh, I want to work on this, and that. And it's like, well, you know, if I'm using at times, and I'm, you know, let's say I'm in recovery or I'm in treatment, and I'm using, and I use when I'm happy, I'm sad at any given moment, and then I go into treatment and I give that up, or it's taken away, then what other positive pro-social behaviors or things can I include in my life? And that's what we really have to focus on. And also focusing on the harm reduction piece. So if someone is in treatment and they are, let's say, shooting up 10 times a day before they come in, and after their first week in treatment, they're shooting up 8 times a day. And then after their first month in treatment, they're using once a day. If you only look at certain aspects like their drug screens, they're still going to continue to have abnormal drug screens throughout the whole process. But what we really want to get to is that point in individuals' lives where it focuses on all the other aspects. So yes, they may still be using, but they've significantly decreased their drug use. But what else is going on in their lives? So it might be that they had their first safe place to sleep last night, first place to sleep in a long time, or they might have had a good meal, or they might have had a job interview, or they might have signed on their first house. There's so many different aspects in the life that we want to focus on. So again, in the treatment setting, it's not just focusing on stopping drug use, it's focusing on the other aspects of their life that help in conjunction with the drug use and can aid in the recovery process. So strategies to tackle the opioid epidemic, this is part of the beginning too, the prevention piece. So there's naloxone distribution, public education, there's community-based prevention programs, there's screening and diagnosis, and that can be done at like the medical provider, you know, going to your doctor and being screened for it. It doesn't have to be only when you get into treatment. So there's a lot of different pieces that are getting involved. You know, when you focus on the engagement treatment, sometimes that's through harm reduction. It can be, you know, national websites, there's treatment locators, there's a lot of different things you can do as far as finding it. There's medication-assisted treatment as a country. There's different initiatives going on. So some of these would be initiating medication-assisted treatment in jail settings, in correctional health. In Maricopa County, I think we have a pretty amazing programs, I should say. The individuals on medication-assisted treatment can continue with their medication and their treatment while incarcerated, and so in the jail and the Maricopa County jail system. And so for correctional health, there's been huge steps in the right direction, and just continuing as a country and the communities to look for access to long-acting medication-assisted treatment. Focusing on retention to care and patient-centered and tailored approaches. That's always going to be the most important part of it. Is it has to be individualized, just because every person is different and what works for you won't necessarily work for me, and it really has to be individualized for the specific treatment needs of the individuals. And then the sustained recovery piece, just finding local recovery support and identifying that. Recovery housing. So, for example, Oxford House and some different housing have residential programs have stepped up. And so there's different things coming out in the communities, but there's been concerted effort on the national level, cascading down to all these different initiatives. So recovery housing, mobile technology to assess and address relapse risk. So there's different apps that different agencies use that might do it. There might be chats, text messaging, so many different things that have changed, just because when working with the opioid epidemic, what we know is that what we've always done isn't working right now. We have to really change it and pivot it and do it in a different way. And so focusing on that and working with healthcare systems, justice systems, addiction treatment programs, community programs, everybody really has to work together, just because there's so many different aspects going on in people's lives when they're actively using or involved in opioids. And how do we address it, not just one-on-one, but all of us together and focusing on it. All right, which brings me to the 24/7 medication-assisted treatment access points. So there are in Maricopa County, there are 3 access points and then 1 in Southern Arizona. And the goal of these is to increase access to medication-assisted treatment services by providing intake access 24 hours a day, 365 days a year. So when someone has that moment of hope and wants to get into treatment, that they can go ahead and go to one of these locations and they can get started on MAT. In the past, I'd say a few years ago, that typically opioid treatment programs were like 4 a.m. to, let's say, noon, 11:30, and intakes, might be first come, first serve, or it might be that they only did them certain days. And so with the different access points, people at any time of day can get into treatment. And that's a pretty amazing aspect to say, okay, 3 points within just the greater Phoenix area, people can get into treatment if they want for medication-assisted treatment. And they work more as a hub and spoke model at times, so people can go into the different locations to seek treatment. So let's say they wanted to, there might be another opioid treatment program right by where they live, but they might only do intakes once every 2 weeks, and they're ready to get in treatment today, so they can always go to one of those locations and then transfer to another location that might be more geographically, closer to them, or it might be closer to their work, or where their say partner goes. It can be a variety of reasons. The access points also support community efforts in decreasing preventable deaths for people actively using opioids, and that's by engaging them in MAT services, but also working with naloxone distribution and providing the overdose reversal kits to individuals coming in treatment, as well as outreach in the community. And then in general, talking about increased education surrounding OUD and available treatment options. And then the access points all partner with local harm reduction networks as far as the naloxone distribution. In general, also just for the outreach, as far as if people are actively using drugs, a lot of times they're involved with the local harm reduction networks. And so having partners in the community, touching individuals who are actively using, just saying, hey, there's help and there's hope out there. People might not be ready for treatment today or for tomorrow, but we always want to let them know that there's an open door and a community out here that cares about them if and when they're ever ready. And if they're not ready anytime soon or ever, we still want to let them know that their community cares about them, and we want to keep them alive and keep them safe as much as we can. And then for the different locations, here are the specific addresses. So I think it's been on every slide. So I'm with Community Medical Services. Community Medical Service, the one on the top left is Kodak. That's in Southern Arizona, so Tucson. This one right here for us, for me specifically, Community Medical Services, is off the I-17 in Cactus. The Community Bridges is in the East Valley, and it's at ARC, and it's off more or less Broadway, and I think just east of Mesa Drive. And then ITS is off 75th Avenue and Indian School. And so again, 3 geographic locations throughout the greater Phoenix area, and they're all focusing on treating and providing that 24/7 access to care for individuals with opioid use disorder. So that concludes my presentation, and I covered a lot, but I know we only had an hour, so wanted to save some time for questions for Q&A, and we'll open it up to questions, and just want to thank you all.
Thank you so much, Tina. Okay, everyone, this is your opportunity to ask questions.
My contact information's up. If you guys have specific questions, you can always reach out to me. We have, different services I should probably talk about in the different, I'm talking specific to my agency, but most of them, especially the different access points, run pretty similarly. That there's IOP involved, there's the counseling, the case management. A huge piece, which I didn't actually touch on that much, which I really should have, is the peer support piece. So I think the peer piece is an integral piece to the to medication-assisted treatment in general. So I think in the behavioral health world, outside of substance use, peer supports have been around for a while, but in the OTP, opioid treatment program, or MAT setting, a little bit newer, I'd say in the past 5 to 10 years. And it's been such an invaluable part of the recovery process, just being able to use their shared experiences. People, when they come into treatment or people who are experiencing opioid withdrawal, oftentimes feel like they're going to die, and it's really scary, and there's a lot of stigma and shame associated with it. And so just walking through the doors can be so overwhelming and can be such a barrier. So being able to greet them as soon as they come in with people who have those shared experiences and themselves are in recovery is such a powerful tool, just to be right in front of you and say, hey, I was in your shoes, I was struggling just like you were, and I'm here for you, and we all are, and it can be so powerful. So As an agency, we typically, all of our peers obviously are in recovery. Majority of our peers are in recovery from opioid use disorder, just because opioid use disorder presents so differently than some of the other substances and other forms or other types of addiction. And so, but again, being able to use your shared experiences is valuable, and having your team members and colleagues, have that shared experience to really fight the stigma and to use their shared experiences with members themselves or with community partners or anything else is just invaluable in the treatment setting.
Looks like we did get 2 questions in. There was one in the chat. Is there an intake to Matt at CAS? Please and thank you.
Is there an intake to Matt at CAS?
Yes, that was the question.
Okay. No, there's not at this time. However, there's a lot of outreach aspects of it. So medication-assisted treatment in general, it's highly regulated. So you actually have to get your first medication in an opioid treatment program. There's definitely outreach that I think probably all the different agents, not all, a lot of agencies do with CAS and involved with Circle City, all of that. But in order to get involved in treatment, you'd have to go to the specific facility to get the medication. That's a great question, though. And then also for outreach, there's outreach going on all the time. A lot of, right now, I'd say a lot of outreach is focusing on people experiencing homelessness, especially in summer months with the heat and just the high risk associated with the Arizona heat in which we live, or I should say Phoenix heat. I think Flagstaff experiences it like we do. There's always different outreach going on, and so what we do is, and I'd say for access points or a lot of the peer-led agencies too that are out there, that because there are a lot of amazing agencies in our community, is they'll go out and then they'll work with individuals and bring them to treatment. And that's one of the benefits of the different access points, is that in the past, if you're outreaching people, you might find someone who's like, I want to go to treatment. And then you'd call like the 20 different opioid treatment programs in the community and see who's doing intakes and when. And now everyone knows that they can just go to any of those 3 access points at any day or time. And people can get into treatment. And so that's one of the benefits of it, of those. And it just, it takes a whole collaboration, just because it takes the whole community working together.
Tina, we have another question. Oh, go ahead, Emily.
Sorry. Monica asked, are people more successful in one type of medication or another type?
Not necessarily. It's really polarizing. So a lot of people have tried one or the other and it wasn't. But there was a slide, I think it was toward the beginning, that shows in general, research has shown that people respond better and do better on methadone than buprenorphine, and then people tend to do better on buprenorphine than Vivitrol compared. But no, it's really individualized. Having been in the field and in my life for a long time, I have people who are near and dear to me whose lives have been saved because all different forms of recovery and all the different medications. So no, not necessarily. But again, there's more research about methadone, so typically shows higher success rates just because it's one of the most studied forms of medication and in the recovery field, or it is the most researched medication in the recovery field. So that has the most research surrounding it as far as the efficacy of it. But they're all effective for individuals, but it's really individualized, that people tend to respond better to one versus the other. As mentioned earlier, some of the barriers between the two between the 3 is that in order to get on the injectable naltrexone, you have to be free of opioids for 7 to 14 days. And that in and of itself can be a huge barrier for people. That's typically where people are relapsing, is as soon as they start to get sick, it just becomes so overwhelming that they use again, not because of necessarily the euphoric effects of it, but because they don't want to get sick, and those withdrawal symptoms. And so that's one of the barriers. Buprenorphine, as mentioned, has buprenorphine, you have to be off opioids you have to be in active withdrawal. So you have to be off opioids for like 12 to 24 hours, depending. So sometimes that can be a little more challenging, but it's not a huge barrier that people can typically get in same day or later, maybe 12 hours later when they come to treatment, as far as getting their first dose of medication. And then the ceiling effect, that for people who it could possibly be that they're rapid metabolizers, those individuals who constantly are still experiencing withdrawal symptoms or cravings after typically like 24 milligrams of buprenorphine. It's not like you can just give them 36, 50 and increase it till they don't experience it. It has that ceiling effect, so that if someone is experiencing those withdrawal symptoms or cravings at 24 milligrams, they might be a good candidate for methadone. It really just depends. There's other physical conditions that might make people more inclined to be on one medication versus another. So we do, most providers will do EKGs, look at your heart rate, everything else like that, just because certain types of things going on in people's bodies kind of prohibit them from one medication or another at times. Good question, though. Another question in there? Or anything else? And for the, I don't know the attendees or participants, and so if you're if you yourself are actively using, or if you're a community member, if you're in the field and you've never been to an OTP, you've never seen MAT, I highly encourage you to come check out the facilities. What you'll see is people like you and me. There's a lot of stigma associated with recovery and MAT, like, oh, it's going to look like this, and what you see in the clinics is everybody. Addiction and recovery, it knows no boundaries, and affects every single way, or it can affect everybody, and no one seems to be immune from it. And so again, what you find in the treatment settings is something very similar, that it's all different walks of life, and you might have people who come into treatment on their first day and they're experiencing homelessness and their basic needs aren't getting met and they don't have any social support or family support. And then at that same time, you might have someone come into treatment and their employer let them off work for a couple of weeks while they can work through this. Their family's there to support them. And we see both those scenarios play out daily, I'd say. So again, it's across the board. It's not one specific demographic. It really affects a lot of people, and you see that representation in the treatment setting as well.
Again, feel free to join us for any of the future sessions, and thank you, Tina, for this excellent presentation.
Yeah, my pleasure.
Thank you.
All right, I'm going to stop